do you think there's a challenge when it comes to general physicians in these smaller towns when I mean, this is something that I've understood over the last couple of months of being researching this, that they don't have the capability to read the ECG
Oh
well.
yeah. No doubt about it.
So what is it that can
See,
be done for this?
India is a very fascinating country. Let me tell you, it's a very, very fascinating country. India has the best doctors in the world, and India has the worst doctors in the world. The range is so much that it is amazing. I tell you, I have worked in India, I worked in Middle East, I worked in UK, I worked in USA. The best doctors are Indian doctors, and let me tell you that you should feel proud that there is a publication from Massachusetts, Boston. These people followed 50,000 patients in that area, Boston area, over 10 years' time, and the trial result was that the patients treated by foreign medical graduates, where Indians constituted 82% of the doctors, foreign medical graduates, their outcome was better, their longevity of patients was better. So Indian doctors are very bright, but in India also it depends on where the doctor was trained, which medical college he came to, whether he went by giving donation or he went to the open merit, or he was taken because he belonged to some kind of reservation area. So there's a lot of variety in India. That's a problem. That's a big challenge. Actually, I was in UK and one of the consultants here, he said, Dr. Kler, I want to ask you one thing. I never understand. Some of the Indian doctors are so bright, they are better than British doctors, but some of them, they're so duffer. What is this? And it's a reality. So there is no uniformity. See, if somebody is MRCP from UK, he will have minimum standard. But MD medicine or MBBS from India may be extremely good, may not be extremely. That's a problem.
No, but I agree that ECG interpretation and diagnosis is something where a large majority of physicians actually shy away from.
Right.
Because this is little tricky. I mean, you need to have you have to spend some time to understand this. That's why even in cardiology, all cardiologists don't try and interpret this. There's a separate subspecialty in cardiology which is called electrophysiology, where we deal with diagnosing and treating this arrhythmia. So this is something which we'll have to spend time to teach general physicians or set specific basic protocols so that they can follow for patients coming to them with some specific symptoms indicating arrhythmia like giddiness, syncope, palpitation. They should do some basic questionnaire, ask some questions, do some basic testing which includes ECG and Holter and echocardiography, and then decide whether this patient merits treatment or this does not. So if these such protocols are there, like there are such protocols there for chest pain, for anything in US or anywhere, where even a nurse can follow those protocols and make a correct diagnosis as compared to physicians. So I mean, if protocols are set, I think, and circulated to even physicians in tier 2, tier 3 or tier 4 cities, I think we can do a significant justice in improving the diagnostic.
No, actually, he's very right. The general physician in this country, see, the physicians are two types. One is who have done MD medicine. There are many who are MBBS only. They started practice, and some of them, they may be very good. But if I have to say, the average standard of ECG interpretation is very poor. And now what we have done is that from my group, we have started ECG Academy. So we do webinar once a month. The first Wednesday of every month, 7 to 8, we talk about only ECG. Different topics at different scenarios. Every month we are doing for last 3 months, and now the numbers are increasing, and that actually this webinar is telecast in Bangladesh and Pakistan and Sri Lanka also. Almost 500 people join and everything. So we want to teach ECG to those people.
One thing just I'd like to, one thing which I'd like to add for arrhythmia diagnosis, like you had mentioned and Dr. Kler alluded to very nicely. There are two important aspects of arrhythmia diagnosis. One is diagnosing in people who are symptomatic. So if someone is coming with the symptoms like giddiness or episodes of unconsciousness, syncope or palpitation, then we straight away start suspecting that he could be having slow heart rate or fast heart rate. Similarly, there are a set of patients who may not be symptomatic, but they are at a higher risk of getting such arrhythmias, like patients with post-MI left ventricular dysfunction. They've had heart attack, their heart is weak. even if they are not symptomatic, they could be having asymptomatic episodes of such arrhythmias, which may not be manifesting, and their first manifestation could be a catastrophic sudden cardiac death. So there are set of situations where you will have to do investigation to pick up asymptomatic arrhythmias, and set of investigations where patients come with symptoms. So if patient is coming with symptoms, surely we'll go ahead and do ECG, Holter. If Holter is not picking, if symptoms are very, very less frequent, we may do loop recordings, external loop or internal loop recorders. All those will help. But similar testing will be required in situations where person is totally asymptomatic but at a high risk of getting arrhythmias, like post-MI LV dysfunction, or a similar situation could be like a patient having recurrent TIA or stroke, where we might suspect person to be having asymptomatic episodes of atrial fibrillation causing clot formation and embolization. So in such situations, even in asymptomatic state, we might need to investigate by doing Holters or remote cardiac monitorings in form of loop recorders, so that we can pick those ailments.
See, now the technology is going to help us. In fact, the modern medicine will be more and more technology oriented, and it is already there, but it will be amazing in future. For example, people who have got palpitation, somebody will say it happened, for 2 minutes, 3 minutes. On 2 minutes, nobody can go and get a EC done. It's too short a time. So we have devices which we can give to the patient, and what they have to just hold in the hand, and the ECG can be recorded. So like Cardia, there are many other devices, handheld devices, which can record the ECG of these patients, and many of those patients can be picked up by these methodologies.
So you wanted to say
Yeah,
something?
the same thing I wanted to tell, which already Dr. Kler has said. The arrhythmias, majority of them are like transient, coming and going type of. In that cases, the diagnosis used to be difficult. If arrhythmia is like atrial fibrillation, or sometimes in the ventricular tachycardia, or like the complete heart block or 2:1 block, they are coming and going. So if ECG, if it is persisting for maybe half an hour and so, ECG can be done. Even then, if the patient is reaching to the doctors and some of them are ठीक है जी ये तो थोड़ी देर में ठीक हो जाएगा, majority of them are becoming okay after some time without getting an ECG done. So definitely yes, at the time of symptoms, if you don't have, it's another problem. But if you have symptom, at least some ECG should be done at the time of symptoms. That is a must. And as the Dr. Sahab was telling, my uncle Mamaji, he was having the same syncope for a few seconds. By the time that he is going to the doctors, it's okay. And he's a CAD, post PTCA, post bypass surgery patient. So ultimately, after 6 years, we were able to find out that he was having transient complete heart block, which is persisting for few minutes. Because of so many times Holters were done 24 hours, 48 hours, it's okay. Once we put the monitor for 10 days and 15 days, then it was picked up. He was having this type of things. So that is a really good thing.
There are many kinds of devices
Definitely,
available.
yes, technology is important in that.
People
kind of cases.
who have got very occasional symptoms, like once a month or once in 2 months, you can't put Holter. There's useless. You can't put Holter. We got external loop recorder, ELR. ELR can be for 1 month, but he says I get problem in 3 months time. So then there are implantable devices. It's called ILR. ILR is the internal loop recorder. It's a very small thing. It's like this much size. This can be just injected with this syringe. You inject it in 2 minutes time. The ILR has the capability to record ECG for 3 years. So when the patient gets next time behoshi or symptoms, we can interrogate from outside and it will tell what was the rhythm of that patient. So we have external, we have ECG, simple thing. We have Holter 24 hour, 48 hour, 72 hour. We have ELR, external loop recorder up to 1 month. But if the symptoms are very infrequent, then there are 2 ways. One is that we do electrophysiological study, get the patient to the lab and we can test them. Another is put them on internal loop recorder.
The other thing was that, deficiency of proper ECG interpretation in the GPs and non-major centers is partly and patchily being addressed by, a lot of systems, the third parties who are supplying, ECG and ECG interpretation, like they are the central console or monitoring system run by people, and they put these devices, ECG plus wireless transmission, devices, which will come to a central monitoring system where algorithmically it will create an alert, and that ECG will be seen by a doctor employed by that entity, and then they will tell in turn that this is a problem, you send this patient immediately to a center. Bangalore and all is being done. Earlier it was by one group. Now a few of my colleagues are doing it, and they are extending it to different places, as well as they are going for the echo also, although that's a different thing. So it made a lot of improvement in detection of ischemia and arrhythmia, especially in and around the Bangalore. So we have seen directly the technology helping us. There's a human element is there, but I was part of that algorithm cross-checking by physicians. So we had said few of them engaged in checking that it's being properly read by the algorithm generated system. So this is one thing which requires a lot of setup and manpower and all, and a routine ECG machine which transmits that. So that has been going on for some time. I think we need to step up on that.
I think my suggestion would be that I was just picking up the point which you said about the cardia. I'm a great fan of cardia, if you ask me. 2011, probably it was launched. And I was in American college meeting in USA. They were giving us $50 discount to attend the meeting and get this. So I liked the idea, so I picked up that machine from them. I think probably one of the first few in the country to get that single lead. And it is very easy to record in the ECG. Sorry.
It's on, sir. Just keep it.
Okay. So when I came as how to use this, I thought. So in my clinic, many patient complains of palpitation and all that. If you do ECG, it takes 3, 4, 5 minutes, but you have to put too many leads on that. So what I did, that I kept on my table. If a patient comes like that, it takes just 1 minute to see on my ECG that whether there is a sinus tachycardia or just heart rate or there are ectopics or anything which is coming. So it gives you within a minute answer to that. So that was very useful to me. But I'll recall to few
Recording
instances.
in progress.
One was that some of my rich patients in Delhi, when they saw this with me, they said, "Doctor, we want to have also for ourselves, for our family. Although we do not have anything, but we want to have." I said, "This will not diagnose heart attack. It will only give you arrhythmias, atrial fibrillation and all that." So they purchased some of them. Many times I got 2 instances after a party in the night, one of the Rotary party and all that. Early morning, 5 o'clock, got a call from one of my friends. He said, "Yeah, mera palpitation ho raha hai, ghabrat ho raha hai and all that." He said, "Mere paas wo hai." I said, "Bhejo." He immediately sent me, I found it to atrial fibrillation. So I said, he was just 42-year-old person, and then I had a binge drinking, 7, 8 drinks. So that atrial fibrillation, I said, go and purchase Fleckerite and all that and take 4 tablets. And he became all right. So this is one of the way. Second thing I distinctly remember, when I was traveling from Delhi to London in my flight, and after 3 hours of the takeoff, there was a call came from the pilot side that any doctor in the years, because there is some serious problem in the. So there was a woman, 60-year-old, the British citizen, but Indian origin. She collapsed while sitting, and then the air hostess, and there were another 2 physicians sitting with them. They were there in the flight. So they found that there was no pulse, nothing, everything. So then they announced any other physician. I went there. I also went there. So luckily I had with me. I put it here. It was PSVT going on. And but there were no recordable BP. I mean, pulse was so fast, very fast for that. So we pushed her to the business class and made the letter. We tried with the carotid, because at that time they were also thinking to land somewhere for an emergency landing to save this patient. And we just did it, worked without any drug. With the carotid massage, the rhythm became normal from 190 or 200, which I saw there, came to 80. Her BP came up, everything went. And then she told me she was investigated Hammersmith Hospital for this symptom, and they couldn't diagnose at that time, probably because of some reason, we don't know. And now, since I had a record, I've sent her through email, and then this was shown to the cardiologist in UK, and she was treated subsequently for RFA. And only 2 months ago, I was with my friend for a holiday in Udaipur, and that one of my friends from Gangaram Hospital, he said, "Ki mera tabiyat theek nahi, I'm ghabrat and all that," because he ran to see the sunset somewhere, very fast. He's 66. So he said, "I'm ghabrat, heaviness or some ghabrat is there." So I had this time 6 lead ECGs, because we upgraded to 6 leads now. So very useful. The moment I put it there, I found there were multiple ectopics coming. and then we can all 6 led no STD changes, but there is no V1 to but multiple ectopic. So we know that there is nothing to I give him a little beta blocker and all that. You settle. So these instruments, these things are very good. And this one, I was last year the ambassador to this Apple Watch, medical ambassador, because they wanted to upgrade it. And so we said not only the atrial fibrillation, we are also picking up ectopics, both supraventricular, ventricular. We are also getting heart blocks. We can pick up by this. So it is not only atrial fibrillation. All other arrhythmias are also be picked up from the Apple Watch. So these monitoring systems are really very useful. And future, as Dr. Kler said, will be definitely working in favor for that.
No, I think it is amazing. Thank you for sharing this, because this is encouraging to know that the technology is making the.
We had a patient. We did angioplasty in Escorts. This is 8-9 years back. So that time we used to go. Some of the patients we used to give them a device. He can put on the chest and ECG will record. So this guy, after about 10-15 days, went to New York. He was in New York airport. So he had some chest discomfort, घबराहट, and he took the ECG and he sent the ECG. It was acute stent thrombosis. So we told him that immediately go to the emergency, and he was saved. So these, anyway, the point is that all these devices, more and more will be available. They are very useful. The device has to be validated from time to time, that it is not just causing anxiety, unnecessary information. So it should be good quality device, having proven scientifically the value of that. So these devices are very useful in cardiology. There's no doubt about that.